Hello and welcome to the November issue of the IJA Authors Podcast. I'm Dr. Gayatri, your host, and joining me today is Dr. Vedhika Shankar, who works as an anesthesiologist at the NHSRCC Children's Hospital, Mumbai. Dr. Vedhika, welcome to the IJA Podcast, and it's a pleasure to have you join us.
Thank you so much. It's an honor to be a part of the team.
Vedhika, I'm personally having, I look forward to having some really fun-filled podcasting sessions with you.
Looking forward to the same. I hope I can contribute.
Yes. So friends, today's episode also happens to be very special because we're going to complete 12 months, that is 1 year of the IJA podcast series. So I can't be more grateful to all the authors who have graced this podcast with their presence, and to all the listeners. All of you have been really kind and encouraging and have been tuning in regularly into our podcast. And I hope you keep supporting us going forward. Today, like we have for every episode, we have 3 very interesting articles. And I'm going to ask Vedhika to start off with the first one.
To start with, we have our first paper, the Adductor Canal Block plus infiltration of the posterior capsule of the knee, more popularly called the iPACK block, versus the 4-in-1 in an arthroscopic anterior cruciate ligament or ACL repair. This is a randomized study. We have with us the primary author, Dr. Ritesh Roy. Professor Ritesh Roy is the clinical director and head of department for anesthesia and surgical ICU at Care Hospitals, Bhubaneswar, Odisha. So your paper on the 4-in-1 block was truly an interesting read, and we're excited to discuss the so-called behind the scenes of it with you today. Thank you for being here with us.
Thank you, and congratulations to the IJA podcast team for completing 1 year.
So let's start with this. The study found that the 4-in-1 block provided comparable pain relief to the combined iPACK and Adductor Canal blocks. Can you elaborate on the mechanism of action of the 4-in-1, what are its targets, and how it achieves such comprehensive pain control?
Yeah, as we published the 4-in-1 block, I think it was almost around 2-3 years back we published it. So if you see the 4-in-1 block, it is mainly the 4 block nerves which we target with a single injection. That is your saphenous nerve, the nerve to vastus medialis, and the popliteal plexus, which is formed by the 2 nerves. That's the articular branch of the tibial and posterior division of obturator. So if you see the anterior ACL repair surgeries, the pain generators are mainly the port site, which is usually supplied by the saphenous nerve, and the intra-articular component, which is supplied by the popliteal plexus. So because of the action of the 4-in-1 block on the popliteal plexus and the saphenous nerve, we get a very good pain relief with a single injection.
So how, and to elaborate a little further on that, how does the 4-in-1 access the popliteal plexus?
Yeah. So if you see where we deposit the drug, if you see it is the deposition of drug just above the adductor hiatus. After the adductor hiatus, your superficial femoral artery becomes the popliteal artery. So we deposit the drug just above the adductor hiatus, around 1 to 2 centimeter proximally to it. And because of the perivascular deposition of the drug along with the superficial femoral artery through the adductor hiatus, it enters into the popliteal fossa, and thereby it blocks the popliteal plexus. And because of the deposition of the drug at the level just where before the descending genicular artery leaves the superficial femoral artery, there the saphenous nerve is blocked. So by a single injection, because of the traveling of the drug along with the superficial femoral artery into the popliteal plexus, we are achieving the 4 nerves block. And obviously the nerve to vastus is not very important in the ACL reconstruction, but the saphenous and the popliteal plexus is required. That's why we get a very good comprehensive pain relief.
All right. Thank you, sir. So I think you've sort of already answered what my next question is going to be, little. What is the difference between the modified 4-in-1 and the 4-in-1
Yeah,
block? And why did you
yeah.
pick one
So
over the other?
yeah, we initially our initial publication was the 4-in-1 block. So and that we started in TKR surgery, total knee replacements. Okay, so after doing around a series of 4-in-1 block, what we found, we used to complain pain on the medial aspect of the knee. Then we went back, started studying all the cadaveric things and everything. So if you see, the nerve to vastus medialis usually leaves in the femoral triangle, it divides into two branches, the anterior branch and the posterior medial, anterolateral branch and the posterior medial branch. And this posterior medial branch, it runs out of the adductor canal. It is not part of the adductor canal. It runs in a separate compartment. So, and the different studies have shown, the cadaveric studies, that if you deposit the dye in the distal part of the adductor canal where we deposit the drug, usually the nerve to vastus medialis is not stained because it lies in a different compartment. That's why to get the nerve to vastus medialis, the nerve to vastus medialis is very important for a knee replacement surgery, not for ACL repair. So in modified 4-in-1, to get that nerve to vastus medialis, we combine PNS, peripheral nerve stimulator, to find the nerve to vastus medialis. That is the modification which we did. So anybody who wants to see what is the difference, they can just Google it, modified 4-in-1 and 4-in-1. They can get the difference which is there. So that's why a modified 4-in-1 is not required in a ACL surgery, because the nerve to vastus is not so much relevant for an ACL post-operative pain relief. That's why we choose 4-in-1 block.
Thank you, sir. That was very well explained and I think very cleared up a lot of doubts. So coming now to the practicalities of this block. In the hands of experts, this block is very effective. How do your trainees and fellows perform this block? And do they perform the block one? And what is the learning curve like? Which aspect of the block performance typically tends to be the hardest for them to pick up?
Yeah. So obviously my fellows, they do these blocks. The learning curve is not so difficult. I will tell you very frankly, the learning curve is not so difficult. You have to identify the coming out of the superficial femoral artery from the adductor hiatus. Just slide your probe proximally. You can see the descending genicular artery branching out from the superficial femoral artery. This finding of the descending genicular artery, it sometimes becomes difficult for the fellows to identify. Okay, but after doing around 10-15 scannings, they are able to pick up the descending genicular artery coming out of the superficial femoral artery. And just we slide a probe 1 centimeter proximally, and that's the point of drug deposition. Okay, so identifying the branching of the descending genicular artery from the superficial femoral artery is crucial, and it takes only 10-15 scans to get it. It's a very simple block. Okay, it's not so much of scientific anatomical anatomy that this is that. It's really very simple. Okay, and secondly, what is most important is the drug deposition, because if you see at that level, you have the epimysium of the sartorius, then you have the vasoadductor membrane. The ideal drug deposition is once you start depositing the drug perivascularly, your artery should dip like this. It should be like a sunset sign. With every injection, your superficial femoral artery should collapse. Then when you stop the injection, it should come back. It means you are in the right plane. So the two aspects which are most important for identification of the site of injection and drug deposition.
All right, sir. So the coming over the next is when you go through your study, we see that the pain scores are comparable till we get to the 36th hour. And we know that both groups received single shot blocks, sir. So what do you propose could be the reason behind the difference at the 36th hour when it comes to pain score?
Yeah, that aspect we had mentioned in the article. It's about the volume because we gave around 25 ml in both groups. The volume of drug was 25 ml. Okay, because of the volume of 25 ml given at one point in IPACK group, it was only 15 ml, and in this it's 25 ml at a single point. So because of that, the duration of analgesia might be more at 36 hours compared to adductor canal and iPACK. So that is
Okay.
one of the reasons.
Okay, sir. And what is the complication that you have seen, if any, which is the most common with the performance of this block? Complication, adverse event, or
Yeah,
something that could...
yeah. Only thing which you have to be careful, because since you are depositing the drug perivascularly, you have to be very careful that you don't puncture the superficial femoral artery. Till now, we have in I think it's almost 4 5 years right now we are practicing this block. I think it's very rarely we have punctured the superficial femoral artery. That is the only complication, which is not a complication. It's a thing which you have to be careful around. And even if you puncture, there is nothing to be worried about. Just stop your injection, press for around 10 minutes, nothing else. You don't have to be. Only thing which you have to be careful, don't puncture the artery. That's the only thing. And
Okay, sir.
obviously, when you are scanning, you have some aberration. Sometimes we see the superficial femoral vein above the artery, which is an anatomical variation. So you have to just scan and be careful that you don't puncture the vascular structures, nothing else.
All right, sir. And finally, how does this study reflect in your clinical practice? Has it brought about a change?
Yeah, since it's a single shot block, okay. Obviously, for us, and if you have seen in my study, we have described the time. Okay, for a study in ACB and iPACK, we took around 5 to 6 minutes, and in this we took around 2 to 3 minutes. Okay, for a study point of view, it's okay. But if you are working in a high volume center, okay, we do almost around 15 to 20 orthopedic surgeries in a single theater. So if you combine that 2 3 minutes, okay, so that 2 3 minutes, if you add on, obviously that saves a lot of time of the theater, okay. And ergonomically, this is a single shot block. In iPACK and ACB, you have to change the probe, okay. For iPACK, you have to use a curvilinear probe. For a ACB, you have to change a linear probe. So obviously, those time you can save. So obviously, if you are doing 1 2 surgeries a day, that time is not much of significance. But for a high volume place, that 5 minutes every case you can save. So if you combine whole day, it's almost an hour you have saved of your time.
Yes, very valuable. Thank you so much. I think we've clarified a lot of the doubts that we've had personally, and it was nice to see what went on, as you came up with this idea and brought it forward. That was very enlightening, sir. We now move on from nerve blocks to central line insertion.
Thank you.
So, friends, the next article that we have, like Vedhika said, is about central line insertion. It's predicting the depth of insertion of central venous catheters using a bronchoscopy-based carinal measurement technique or the Perez formula-based method in adults undergoing cardiac surgery, a randomized comparative double-blind study. And to talk to us about this article, we have with us Dr. Satyajeet Misra, Professor of Anesthesiology and the Dean of Research, All India Institute of Medical Sciences, Bhubaneswar. Dr. Satyajeet, welcome to the podcast.
Thank you, Dr. Gayatri. It's an absolute privilege to be part of this show. And my congratulations to you on completing 1 year of your much valued podcast series.
Thank you very much. I must say that all the authors that have come in as guests on our podcast have been very kind, and our listeners have been very kind as well. So, Dr. Satyajit, I was very interested in reading your article, and I want to ask you a few questions. So, the Perez formula has been commonly used to calculate the depth of insertion of central venous catheters. What made you think that we need a different approach? Or if I may ask, what is wrong with our current methods of measuring the central venous catheter depth?
Thank you. So if you really look at it, we have innumerable techniques or methods to sort of predict the depth of insertion of central venous catheters. Yet there is no single method that has been widely adapted or acceptable to the practitioners all over the world. Main problem with the Perez method is that the formula was developed in Caucasians who are typically larger than Asians. And so therefore, when the same formula was applied to the Asian patients and even in the Indian context, the catheters would tend to occupy a more deeper position. That means that it would be well below the right atrium superior vena cava junction, which is so-called the dreaded zone, below which we shouldn't be placing the central venous catheter. So in that sense, the Perez formula has a lot of shortcomings, and it is not an ideal formula to be applied in the Indian context or even in the Asian context. And we thought that, we should always look towards trying to search for better alternatives and means. And so why not use a different method to predict, which would be more like an individualized method, because each patient will be measuring the carina and based on certain formulas or nomograms and certain stuff. So that not be a population-based measurement. It would be an individualized measurement.
That's nice. What got you to explore bronchoscopy, though, as a tool for CVC depth measurement? It's quite an innovative leap from its usual use, isn't it? So, was there any particular patient case or clinical experience that sparked this idea?
Actually, the funny thing is that we use the carina as a reference for citing the depth of insertion of central venous catheters. And the way we look at the carina is we usually use a preoperative chest X-ray to sort of image the carina. Now, we do a lot of thoracic cases, and every day we are using the bronchoscope, and daily we are putting the double lumen tubes or the bronchial blockers. And the carina is our favorite landmark using the bronchoscope. So it was just a question of, serendipity. And we thought that if we can directly see the carina and we can sort of use that same carina to make the measurements, then can we do away with, taking these radiographs, which may not be optimal. For example, patients may not X-ray, or if you're putting the visualization would be poor, or if you're using these X-rays in the post-operative period to predict the depth of insertion, then you would not be having the posterior anterior views. You would be having the AP views. Many surgeries where a central venous catheter is actually put, a chest radiograph may not be indicated. So you would just to have a preoperative carinal view for measurements, you would have to do an unnecessary investigation. So bronchoscope is a routine armamentarium, and it's like used by not only cardiac anesthesiologists, but also by non-cardiac anesthesiologists world over. So we said, why not use the bronchoscope where you can directly see the carina and sort of make the measurements.
So you just said that the carina is a favorite reference point. So for our young listeners, could you explain why the carina is such an important anatomical landmark?
Yeah, so basically when we don't have any sort of reference point for the RA-SVC junction, which is where the central venous catheters, should be placed above the RA-SVC junction, is our traditional teaching. Because if you place it below the RA-SVC junction, then there's a chance of pericardial tamponade, vascular injury, atrial fibrillation, and so on and so forth. How do you position these catheters then above the RA-SVC junction? So that is where the carina comes in handy, and the carina has a unique relation to the RA-SVC junction in the sense that it is somewhere around 2 centimeters above the right atrium superior vena cava junction, right? So if you put the central venous catheters just above the carina, then you are supposed to be roughly 2 centimeters and a half centimeters away from the RA-SVC junction. So that's how the carina is a very useful reference point, because it has got a predictable relation to the RA-SVC junction and roughly around 2 centimeters proximal to the RA-SVC junction. So if you just put the central venous catheters at the bifurcation or at the carinal, just above the carina, that means that you are around 2 centimeters above the RA-SVC junction.
So Your exclusion criteria focused on the use of transesophageal echocardiography availability. Did you consider including patients with other imaging modalities, and what made you specifically choose for TOE as your gold standard?
Yeah, so okay. Intraoperatively, we have limited modalities to image the RASVC junction, right? So one of the best modalities is use intraoperative echocardiography, and since we are doing cardiac surgery, and the transesophageal echocardiography is a standard of care in patients who are undergoing cardiac surgery, we can easily use it to image the RASVC junction. So the views are very easily obtainable, and it's seen in almost all patients. And the other modalities like intraoperative fluoroscopy and all those things are not commonly practiced. So we used something that is very commonly available with us, and it is used almost in all cases to interrogate the cardiac structures. And one of the views is you can just go for the bicaval view and see the RASVC junction in the bicaval view on the TOE, and that's where your central venous catheter should be just proximal to the RASVC junction.
Now, coming on to your results, your results showed a dramatic difference between the two methods. There was 87.8% accuracy with the bronchoscopy versus the 37.5% with the Perez formula method. Were you surprised by how big this difference was? Like you said that, the difference in height between Caucasians and the Indians you expected, but did you expect such a big difference?
No, because for our sample size calculation, we had actually taken an accuracy for the Perez method to be around 50 to 60%, around 60%. So in that sense, we got it, the accuracy was even lower. So yes, we were surprised, but the only explanation we have is that, the formula was not designed for Indians, and so therefore it cannot be very accurate in Indians. Yes, it was a little bit of a surprise, but it was a happy surprise for us, because if you get a significant difference, it sort of proves the whole hypothesis that you had started out with.
While the accuracy is impressive, some might worry about the extra time needed for the bronchoscopic measurement. Could you share your experience about the practical aspects of implementing this technique in a busy cardiac surgery setting?
Okay, yeah. So I would say that yes, the measurements would take roughly around 5 minutes. Because you need to be precise with it. Maybe around 3 to 4 minutes, but definitely on an average, it would take 5 minutes. And yes, so that is an extra time that needs to be given. But when you look at the results, and when you look at what the potential implications of these results are, then I think 5 minutes is not a waste of time. And that is the way I would put it.
Another thing that I wanted to ask you is your methodology involves some precise measurements from carina to the tube end, then from the mouth angle to the connector, from the cricoid to the tube. How did you ensure standardization of these measurements among investigators? What I mean to say is there's so many measurements. So how did you avoid, the inter-investigator measurement variations that could occur?
Thank you, because this is a very valid and a relevant question. So before we actually started the study, all the investigators who were involved in making the measurements, we sort of standardized the measurements, and we made sure that all of us were on the same page as far as the measurements were concerned. Where exactly do we measure? How do we measure? So before we actually started off per se with the formal investigations for our study, we sort of did the measurements over a few patients. We had around 15 to 20 patients over whom we did the measurements, and we looked at, and each of the investigators roughly looked at 4 to 5 patients and saw how the measurements were, and that is how we standardized the measurements between the various investigators. So when we did it, we made sure that all of us were there, and we sort of looked into how each one was doing the measurements and whether there was any errors. And so we corrected all those things before we started the actual study, because when you do the study, it's not possible for everyone to be there at the same time. So we made sure that all of us were on board with the technique before we actually started the study.
I also read that you used, I think in one of the measurements, you also used vernier calipers. And was that also, a measure to
you can use a
prevent this
caliper,
kind of
because
an
when you
error?
when you measure the distance from here to here, it has to be sort of you have to use calipers, or you have to use a goniometer. Without that, you can't measure it. So you have to use calipers. Yeah, so those are the added paraphernalia that is required for these measurements.
So coming on to some kind of a little bit of a patient safety aspect, while your paper mentions no desaturation events during the bronchoscopy, what safety measures did you implement to prevent complications during the brief ventilator disconnection?
So we did the measurements after the induction of anesthesia when the patients were in a stable phase. They were mechanically ventilated. The saturations were robust. They were above around 100%. And there was continuous real-time monitoring of the oxygen saturation. So with the plethysmography. So anytime the saturation with the cutoff threshold was 95%, anytime it dips below 95%, we would stop the measurements, put out the bronchoscope and reconnect back the tube and put the patient on 100% FIU. Thankfully, we did not actually have to do it in any patient because measuring the carinal length with bronchoscopy is ridiculously easy once you know how to do it. It's just a 1 minute job. It's less than a 1 minute job. So I don't think that problem of desaturation is very important.
So looking ahead, do you envision this bronchoscopy technique becoming a new standard of care for CVC placement, or do you see it occupying a more specialized niche role?
I think it would make me happier
what
if it becomes.
excites you most about the future potential of this novel technique? And do you think there are any barriers that need to be overcome for its wider adoption? This is a long question.
Yeah, thank you. But I'll take the first question first. So nothing would make me happier than this being a standard of care, because then something we would have done would have changed the practice. Where I see the biggest potential is, we used TOE only to validate the position of the catheters in the study. So in future, if you just use the bronchoscopy measurements, you actually don't need a TOE to validate the position because we have already done it in the study. So where we would see a wider, we would like to see a wider application of this is in patients who are in the intensive care unit and requiring central venous catheterization, or even patients who are undergoing major non-cardiac surgery where fluid shifts are anticipated and you need a CVC. Use the carinal measurement technique with the bronchoscope and sort of put the catheter and forget about it and think that, feel with the knowledge that it's in the right place. Oh, sorry, could you repeat the second part of your questions?
So I was just asking you what excites you most about the future potential of this novel technique, which I think you just mentioned.
Bronchoscope is really available. I mean, there is no unit now. It's just like an ultrasound. There is no unit now which does not have a bronchoscope. So a flexible bronchoscope is almost like a routine, armamentarium for the anesthesiologist. And therefore, if you have it, why not use it for uses other than just positioning the endotracheal tube? I think we can look at more and more uses of the equipment that we have in our disposal.
But what barriers do you foresee that might need to be overcome for its wider adoption? People have been putting the central line for years now.
And they'll continue to do that. The biggest barrier would be the precise measurement techniques, because that's a little bit of a time-taking thing. And so if it's a very busy unit and all that, probably that may be sort of a hindrance. And so that is where I think there can be a little bit of a reluctance to use this. But beyond that, once you know how to do this, the technique is actually quite easy.
Thank you, Dr. Satyajeet. I think it was a very, very interesting read. I think everyone must just go and read your article just to see how, I think some of the measurements that when we read for the first time appear to be very complex, but they're very interesting to read. And thank you very much for joining us at the podcast and clearing all my doubts. It was a pleasure to have you with us.
Thank you. Pleasure was all mine. Thank you so much.
So, and friends, so the last article for today, we're going to ask Vedhika what she's got for us.
So for our final paper this evening, we have Dr. Sriganesh Kamath, Professor and Head of Department of Neuroanesthesia and Neurocritical Care at NIMHANS. He's the primary author of this very riveting read, sir. Your paper, which was titled Hypotension Prediction Index for Minimizing Intraoperative Hypertension, a systematic review and meta-analysis of the randomized control trials. You're looking ahead. The AI is now, it's here, and this is a very, very relevant read to our times. We just wanted to discuss a few of the questions that we'd had regarding your paper. Welcome to our podcast, sir.
Thank you, Vedhika, for having me, and congratulations once again on this milestone of completing 1 year. And many more to come.
Thank you very much.
Thank you, sir. So, how did you come about with the idea to look into HPI? That's one, sir. And have you used HPI yourself?
Yeah, so the idea to look into HPI came basically after we procured this software tool as an upgrade to our existing hemodynamic monitoring system of Edwards Life Sciences, which is the EV1000 system, which you all use flow track every day. I was planning RCT for one of my DM student, and we observed that only few trials of small sample sizes were available. And most of these studies had equivocal evidence that some of them showed a positive benefit of using HPI in practice and some did not. And therefore, we thought it apt to undertake this systematic review and look into HPI evidence to inform its role in our day-to-day clinical practice.
Okay, sir. So the hypertension prediction index seems promising, but are there any practical barriers or challenges that anesthesiologists face when trying to integrate the HPI into their work?
No, the idea of using artificial intelligence and machine learning to predict intraoperative hypotension before its actual occurrence is very promising to all of us. Considering that hypotension has high prevalence in our practice and also adverse consequences of hypotension, especially in vulnerable populations, such as acute kidney injury or myocardial infarction or stroke, etc. Of course, there are some challenges that anesthesiologists can face when integrating HPI. But most important I see is the cost. Second point is that if you're already familiar with the EV1000 system of flow track, this will be a smooth transition or an upgrade. So that should not be a problem. For others, those are not familiar with this system, it may require a small learning curve to familiarize with technology. The second challenge, or what I see, is the threshold for hypotension definition is fixed in this system, that is 65 millimeter of mercury for MAP, which might be different in different clinical settings and different surgical pathologies or populations. So apart from this, I don't see many challenges with regards to integration of HPI in our work.
Okay, sir. So when it comes to, as you mentioned, managing hypertension is a very critical component of what an anesthesiologist does day to day in all cases, specifically in vulnerable populations. Do you think the HPI could potentially solve this really massive part of our intraoperative workflow?
That is the hope with which the company has invested a lot in R&D, hoping that it will potentially change the practice. As of today, there is, as I mentioned, very limited evidence with small sample size RCTs. But there is promise that it will help to manage intraoperative hypertension better than what we currently do, especially in vulnerable population.
The flip side to this, sir, would possibly be a large part of our training and our focus during anesthesia residency early years is understanding what are the possible causes for the hypertension. Do you think that if we rely on the HPI index too much and reduce hypertension to just treating a number, that we would lose a certain aspect of our clinical acumen?
Well, the HPI is not just a number to start with. So the monitor provides an opportunity to understand the potential causes and helps in guiding individualized care pathways by providing a secondary screen. For those who are familiar with this monitor, it provides a secondary screen where a value more than 85, the treatment intervention part. And apart from the routine blood pressure and heart rate and other advanced cardiac parameters such as cardiac output, SPV and SVR, this monitor also displays three other parameters called SPV, that is the systolic pressure variation, and peak arterial rate of arterial pressure, the dP by dt, and then dynamic arterial elastance. So these three are three different treatment interventions for monitoring. So it helps us to guide appropriate fluid or inotrope or a vasopressor, which the only monitoring of blood pressure alone might not help. So that way it helps not only in identifying the cause for hypotension, but also helps understand how the patient respond to the intervention or the treatment that we administer.
So it will also help guide how you manage the event that is likely to happen. So
yes.
Yeah. Thank you, sir. So and a very interesting point that you mentioned in the article, it mentions that the sample size was slightly smaller than the ideal calculated size, raising the possibility of a false positive result favoring HPI use. Could you elaborate on this, sir, and what specific aspects of future studies would be most important in confirming your conclusions, that is favoring HPI?
Yeah, we made that statement in the article that the sample size may be less based on the recommendation of the reviewers to perform a trial sequential analysis. Routinely, we don't do a sample size estimation for systematic reviews. But since this was suggested by the review, considered that and performed a trial sequential analysis. And we found that our sample size of 564 was less than the information size or the required sample size of 664, which might suggest that a false positive beneficial effect is possible considering this limitation. This is what this suggests is that future results may be altered if additional trials are put in this meta-analysis. So it is like a p-value can get changed with the addition of few patients' data if it is closer to 0.05, let's say it's 0.045 or 0.055. So that way, the interpretation of the results would be. Your second thing was what aspects should future studies look into to confirm the
Yes.
conclusion. Some studies which in our meta-analysis use this outcome measure, that is area under the hypotension threshold, which is the depth of blood pressure below the threshold of 65 millimeter mercury MAP, and the duration for which this remained below 65 millimeter mercury over the cumulative measurement period. That would be more important rather than just 1 minute of hypotension, which is the incidence of hypotension, or the duration of hypotension alone. It may not be so severe. A value of 64 may not be meaningful. So I think future studies should use this as an outcome to confirm or validate our findings. Question was regarding the sample size in this meta-analysis. Well, this was the finding of our trial sequential analysis, and this was at the suggestion of the editorial team, and we have editor-in-chief of IJA, Dr. Rakesh Garg. I request him to take this on my behalf.
Thank you so
Dr.
much,
Rakesh.
Dr. Sriganesh, for absolutely a wonderful systematic review and meta-analysis. And Vedhika, madam, with your permission, can I answer this question, please?
Sir, absolutely, floor is yours, sir.
So I think during the review process, we did ask Dr. Sriganesh and team to do the trial sequence analysis. It is nothing different. I think IJA is now, during the review process, with the help of reviewers, we are asking a little more concrete outcome even from the meta-analysis. Though when we talk of the evidence of hierarchy of the evidence, we say that systematic review and meta-analysis is one of the top one as compared to the clinical trials, including the RCT. And even when we do the meta-analysis, there are many limitations to it. And when we want to remove those the limitations, like for example, the risk of bias, we usually talk about the quality of studies, we talk about the heterogeneity in those things, which can create bias. Similarly, when we want to conclude from a study, we want that the number of participants or the number of studies with participants, even in that meta-analysis, should be sufficient enough to give us some concluding remark. This is as simple as a randomized controlled trial. I'll give you another example. Say when we do a RCT, I think this is a mandatory requirement to do a sample size for randomized controlled trial, isn't it? We put some a priori, some objective, we put fix some alpha values and power of the study. We have some meaningful expectations or the existing studies or the pooled data for the standard deviation with mean, and then we calculate the sample size. Similarly, when we talk about the futility of an intervention or a beneficial effect of an intervention for a meta-analysis, we also put some boundaries into it. And these boundaries are defined by something called trial sequential analysis. And that's why we suggest the authors who are doing meta-analysis to provide us the data for trial sequential analysis. And this gives us the required information size or the optimal information size, which is as per the number of participants included. It's a software based, but then interpretation needs to be done. So I'm happy that the authors for this study related to the HPI also did the same thing. And it gives some reasons for us that whether future studies in these areas are required or not. If the target sample size or the target information size is achieved in this meta-analysis, and our objective was solo and the quality of studies were good, we confirmed that no more RCTs probably would be required for that primary objective. If they are not, even this meta-analysis is not conclusive and we need more studies, and probably in future, updated meta-analysis will be required. I think this is, I'm adding another term, something called updated meta-analysis. This is another information for the authors who are listening to us on this IJA podcast, that if some meta-analysis has been done and we see that TSA has not given us the sufficient sample size to conclude, we will continue with more RCTs, and maybe a later date when we have those numbers, we will do a updated meta-analysis. So it will not be a new meta-analysis, it will be labeled as updated meta-analysis. So these are the terminologies which are emerging in the arena of systematic review and meta-analysis, which is proudly the IJA has taken forward. Over to you, madam.
So that's ingenious. I think very innovative, sir. More power to IJA going forward. And so as a spin-off from this question, now that we've discussed the TSA and the quality of the study and the sample size, what aspects do you, sir, Dr. Sriganesh, do you suggest that future studies should focus on to confirm your conclusions about the HPI's effectiveness?
The HPI provides several other outcome parameters as well. And out of which I believe the area under the hypotension threshold is most important, because it also not only provides the hypotension incidence, but also what depth of hypotension has occurred for how long. And this is a more meaningful utility of this tool. And therefore, I think future studies should use this as one of the primary outcome in future RCTs. Some of the RCTs have already done that, but majority of them have only reported on the incidence or the duration of hypotension.
Yes, sir. So
and I must congratulate Dr. Rakesh for initiating this new aspect of meta-analysis as well. Congratulations to IJ and Dr. Rakesh.
Thank you so much. I think journal runs with the contribution of good researchers. Dr. Sriganesh, I know you personally, and you are one of the excellent researcher and academician, in addition to a wonderful clinician and a person also. Thank you so much.
Thank you. And I learned from this suggestion, because I learned this new analytical technique as well. So thank you for helping me learn.
Thank you so much, sir, for your responses and answering. The final question to you, Dr. Sriganesh. In what specific patient populations or surgical scenarios do you believe that the HPI system would be less effective or would not be valuable for use?
Well, if you are expecting not much of hypotension in intraoperative period, then spending time, energy on using this tool may not be worthwhile. But specific population, vulnerable population, patients who had prior stroke or likely to develop stroke because of intraoperative hypotension, myocardial infarction, recent myocardial infarction, patients with who are likely to develop acute kidney disease. These are some of the vulnerable population, elderly population, and where intraoperative hypotension occurrence is likely to be high. These are specific population where it may be useful and reliable as well. But the major impediment for this is the cost, as I mentioned. Though we have invested, but we are using it in a very specific population, which I mentioned. Other problem with HPI, I find, is the fixed threshold of 65 map, which may not be universally applicable to all surgical pathologies or all procedures and patients. Other than that, another limitation which I observed is that this early warning system of HPI does not evolve with changes in blood loss during the procedure, and therefore it does not absolutely prevent occurrence of hypotension, though it decreases its occurrence to a great extent. And last is despite the monitor being available and giving alarms, if the human element, that anesthesiologist, does not intervene, then you're not going to achieve much benefit from this tool. So these are some of the limitations I see in using this.
Thank you, sir. This was very useful, especially now that AI is, it's ubiquitous almost in conversations and talk. To hear it from you and your experience with its use is very interesting, sir. Thank you so much.
Thank you, Vedhika, for having. Thank you,
Rakesh, I had this whole speech ready to announce your surprise entry into the podcast, but then you came in like a true superstar, like always. And I'm so glad that you've joined us, because do you know that it's a special episode of the IJA podcast today?
Thank you, madam. I think I am not the superstar. I must thanks and acknowledge the superstar for IJA podcast. And I have no hesitation to say that the IJA has superstars in the form of Dr. Murli Thondabavi, Dr. Gayatri, and Dr. Rashmi. These are our IJA ambassadors. These are our superstars. I just take the laurels, but the whole hard work behind the scene and front of screen are done by these three gentlemen and gentle girls. Girls are always gentle girls. So they have done an enormous good amount of work in critically analyzing the various publications, bringing out the nitty-gritties from various articles, and exploring the mind of various experts and the editors to bring out some key messages for readers of Indian Journal of Anesthesia across the world. We have completed almost 1 year. It's, I think, 1 year now.
Today's episode, we finish 1 year of recording the IJA podcast.
Absolutely. So I think my hats off to the three persons, Dr. Murli Thondavavi, I repeat, Dr. Gayatri and Dr. Rashmi. And now we have joined back with another to-be superstar. I think she is superstar, Dr. Vedhika Shankar, also with us in this team. And
we have Dr. Karthik as well.
And Dr. Karthik also. And I'm sure that this journey of Indian Journal of Anesthesia for last 1 year has been quite learning exposure to me. Even though looking the articles, reviewing them, giving them critical remarks, sending it back to authors for revision, and then finally editing it, it gives me a learning exposure because all the authors have contributed an enormous amount of time and mind to bring that article. And then when we try to polish them up so that the message goes clearly to the authors, it comes into publication. But then publication has its own limitation because authors have spent 2 years, 3 years. If you see their number of articles will be there 30, 40, 50 articles. They will have a long Excel sheet and so forth. And we try to concise them into 2,500 words. So probably many of the authors' thought process would not have been put into words into the publication. And this is IJA felt so. And IJA podcast was way forward to understand the thought process of the authors, to express their wisdom, to express their experience during the journey of their hard work of the research, and to explore more that the other readers can take it forward and benefit the patient outcome. And I'm sure that this journey of IJA podcasts definitely would have helped the readers, the academicians, the clinicians, not only across India. The IJA podcast is getting popular globally, and a very good feedback is coming from people across the globe. I'm sure we will continue working hard on this. We will have more bigger team, and the mentors, Murli, Gayatri and Rashmi, will continue mentoring us. More people will enter into it, and we will keep informing the readers to the latest updates so that our patient gets the benefit. Finally, whether it is academician, researcher, podcaster, publisher, finally we want that our patients should get the benefit. They should get the best care. And that is what our purpose is. I think we are achieving to a large scale. And once again, I congratulate every one of you, the IJA ambassadors, the whole IJA editorial board, the Indian Society of Anesthesiologists Governing Council, and all people who has been helping IJA directly and indirectly to bring so much of informative material in the form of podcast, video graphics, infographics, reels, quizzes, and so many things that, see, we have choices, and then IJA give the choices to learn more. Thank you so much once again, and heartiest congratulations to the whole team among us for completing one successful year of IJA podcast.
Thank you very much, Dr. Rakesh, for your kind words. And I totally agree with you that we, the IJA podcast team, all of us are really thankful, especially to all our authors and all our listeners for being so encouraging and tuning in to our podcast every month. Dr. Rakesh, before we wind up, I just have one question. We are now probably counting down to the new year. And you just mentioned that IJA is taking up some really interesting projects. So do you want to talk to us about what plans are for the new year?
I think every day is a new year for me. Every day is a new day. So we want that some good articles are there and we get more wiser. But yes, IJA on its journey will have something new. And we will try attempting releasing a themed issue solely on the systematic review and meta-analysis very soon. When, how, please wait for some time. But I'm sure that one complete issue will be on systematic review and meta-analysis very soon. And it will give us understanding of not only the author's work of systematic review and meta-analysis, but we'll also try to put the understanding of the meta-analysis, how to understand those graphs, which sometimes we say forest plot, sometimes we say ROBs or Robbins or now TSA. So we'll try to put those things also into that themed issue. And I'm sure that this will be informative so that some of us who may not be well versed reading those manuscripts, they will be more wiser to look on those graphs and understand that what actually authors means. This is coming up, and I'm sure that the IJA will continue going up. I also request our authors, researchers, academicians, clinicians, anybody who has any suggestions, ideas for us, any critical appraisal for the journal, please feel very free to communicate with me. And I'm sure, and I assure you, that we will try to bring that better change into the journal, because journal is for you, journal is by you, and journal is with you only. And all your contributions will be really appreciated by whole editorial board of Indian Journal of Anesthesia.
Thank you very much, Dr. Rakesh. I must say that IJA has really flourished under your leadership, and we're really proud to have you lead us in this journey. Thank you very much once again for joining us on this special episode. And to all our listeners, thank you very much for tuning in. And like always, stay safe and stay curious until we see you next month with another exciting episode of the IJA Authors Podcast. Until then, stay safe and stay curious, like I said before.
you.